And now, stand-up community subscribers and listeners from around the globe, it's time to Stand Up with Pete Dominic, where we ask the important questions that impact you, your family, and your community. Such as, will I need a therapist to deal with residual guilt from my dishwashing soap creating grotesque animal mutations? And with Russia still aggressively moving toward war in Ukraine, will NATO need to intercede to quell the conflict? And also, puberty. And now, the podcast host whose prepubescent body says, yep, I'm just like a 12-year-old trapped in a shed, Pete Dominic!
Yes, that's right. A 12-year-old trapped in a shed that is actually in a 46-year-old body. My ankle hurts, and I don't even know why. Don't even remember injuring it. Makes no sense, but I think that's what starts to happen at the age of 46. And then you start worrying, is it a disease? Do I have an ankle disease of some sort? Is it some kind of ankle tumor? And then it goes away in a couple days, and you are embarrassed that you were worried. Hello, my friends, and welcome to today's episode of Stand Up. I've got an awesome couple of guests for you today. Dr. Aaron Carroll, who's one of the all-time greatest of all time. And for the first time, Dr. Andrew Kolodny, who is an expert on the opioid epidemic, and he's an academic on the opioid epidemic. How about that? Really smart guy, very good interview. Happy to have him on. I've told you a couple of recent headlines about what's going on with that, and so I wanted to get someone on and learn from someone, and I think I found the best guest. So, Dr. Aaron Carroll, Dr. Andrew Kolodny, both join me today. How are you? Thank you very much for downloading the podcast, for telling your friends, for writing a review, and for subscribing. I can't do it without your paid subscriptions for just as little as $5, folks. Go to standupwithpete.com, standupwithpete.com right now and sign up if you haven't already, or else the podcast is going to have to end because I won't be able to keep coming out here in the shed and doing it if we can't keep the subscriptions up. So sign up now if you're listening, and I really appreciate it. Now, speaking of which, why do you listen? Well, I got a great recap of the news every day, every Monday through Thursday. I recap the news for you, everything you could possibly want to know, all in 20 or more, a few more minutes sometimes. Let's do it right now. Time for the last 24. All right, let's start with a joke, shall we? It's always good to open with a joke, right? Well, here is the President of the United States doing a little stand-up comedy. He reminisced about his time serving on the Newcastle County Council, Delaware, during an address at the National Association of Counties, and he absolutely takes the house down with this very hilarious joke.
I got a call one night. A woman said to me, obviously not of the same persuasion as I was politically, called me and said, there's a dead dog on my lawn. And I said, yes, ma'am. I said, have you called the county? He said, yes, they're not here. And I said, well, I'll get him in the morning. She said, I want it removed now. I pay your salary. So I went over. I picked it up. She said, I want it out of my front yard. I put it on her doorstep. But I've got much better since then.
All right. I think he nails it right there, the president. His timing is great, but I thought he was a ineffective, sleepy, dementia-plagued old man. Certainly didn't sound like it in the telling of that joke yesterday, and he didn't sound like it later on in the day when he made a point about not underestimating Vladimir Putin, who has been pretty good at outmaneuvering the West in the past, obviously destabilizing our politics. So it's easy to overrate him. But the New York Times, who's Tom Friedman, I don't usually really like, but I don't know. I thought he was pretty right about this, where he writes last night, the Ukraine story is far from over, but if Vladimir Putin opts to back away from invading Ukraine, even temporarily, it's because Joe Biden, that guy whose right-wing critics suggest is so deep in dementia he wouldn't know Kyiv from Kansas or the AARP from NATO, has matched every Putin chess move with an effective counter of his own. And here he is yesterday making sure that no one sleeps on Vladimir Putin.
The Russian defense minister reported today that some military units are leaving their positions near Ukraine. That would be good, but we have not yet verified that. We have not yet verified the Russian military units are returning to their home bases. Indeed, our analysts indicate that they remain very much in a threatening position. And the fact remains, right now, Russia has more than 150,000 troops encircling Ukraine and Belarus and along Ukraine's border.
And here is the NATO Secretary General Jens Stoltenberg. I don't know how to say his name, but a former Norwegian prime minister, on the latest with Ukraine-Russia.
There are signs from Moscow that diplomacy should continue. This gives grounds for cautious optimism. But so far, we have not seen any sign of de-escalation on the ground. Russia has amassed a fighting force in and around Ukraine, unprecedented since the Cold War. Everything is now in place for a new attack. But Russia still has time to step back from the brink, stop preparing for war, and start working for a peaceful solution.
But then there's the headline at the Washington Post. Russia aims to ward off NATO in the event of a Ukraine invasion, as Russian President Vladimir Putin sends mixed signals about his willingness to invade. His military continues to undertake activities that appear designed not only to ready an offensive, but to thwart any attempt to intervene. So very confused as to what is happening there. Reporting on the ground seems to be conflicting. Diplomatic reporting seems to be different stories. So we'll keep our eyes on what is happening on the border of Ukraine and Russia. Will they or won't they attack, and who will get credit if they do or don't? So much at play, and obviously the most important concern, the innocent lives caught in between. I'm doing my best to connect with Terrell Starr, who is there and reporting on the ground in Ukraine. Hopefully we'll have him on the show this week. But let me know what you're seeing, hearing, thinking, who you're reading and paying attention to. I always want to get as many resources as I can on this and every other important news story in the country. All right, well, let's go to the U.S. Senate, where yesterday there was a hearing at the Senate Committee on Banking, Housing, and Urban Affairs, and Senator Sherrod Brown of Ohio is the chairman, and he said there should be a lot more regulation behind things like cryptocurrency, and I thought this is a really important comment. You watched the Super Bowl, you saw all those cryptocurrency ads. Well, here is the senator from Ohio.
If you watched the Super Bowl on Sunday, you saw ad after ad for a product that most Americans have heard of, but almost nobody knows what it really is. Even many of the people who've bought it often don't really understand it. Big crypto companies are looking to make big profits, are desperate to reach as many Americans as they can. They brought in celebrities and gimmicks to make crypto sound exciting and daring and profitable. But the ads left a few things out. They didn't mention the fraud, the scams, and the outright theft. The ads didn't point out that you can lose big in crypto's huge price swings. They didn't tell you about the high fees pocketed by the crypto companies. They sure didn't explain that crypto markets lack basic investor protections and oversight.
So where are you on crypto and the regulation of crypto, et cetera, and so on? I think that's a really important issue to talk about. All right, well, I now want to jump to something very different. Tucker Carlson, in my opinion, has to be the most dangerous and influential person in America, although longtime listener Derek Lowther writes, maybe I should probably add Rupert Murdoch to that. But it's easy to ignore this guy. But from his push for American theocracy to his denial of science on climate and vaccines, his white supremacy, in my opinion, he is the worst. And here's a quick clip of what's going on in Tucker's world last night on Fox News.
So it's been an action-packed day. In other news, Canada became a dictatorship today. It actually did. No longer democracy. Justin Trudeau has declared that he is fully in charge.
All right, so that's what's happening on Fox News in prime time. He is an absolute lunatic, an insane man, a fire starter. He's trying to burn it all down, and he's doing a damn good job of it. I have a feeling, based on nothing, and without even looking it up, that he talks to Steve Bannon like every day, and that they plot together each and every day. But what do I know? All right, let's jump to yet another important story. Yesterday, We got news in a major development that a gun company agreed to settle liability claims from families of a mass shooting, specifically 5 adults and 4 children killed in the massacre at Sandy Hook Elementary School, according to a new court filing. Now, this marks the first time a gun manufacturer has been held accountable for a mass shooting in the U.S. Remington agreed to pay the families $73 million. Here's MSNBC's Joy Reid with a Newtown mom, Nicole Hockley, on the Sandy Hook lawsuit, succeeding in holding a gun maker accountable for irresponsible marketing specifically.
I want to congratulate you all for staying in that fight. And the thing that I found really interesting about the way you did this fight is that you guys weren't backed down by the fact that these immunity laws protect these gun manufacturers. You said, no, it's the way they marketed it. And then you also asked for something important. You wanted the records, the internal records. Please tell us about that.
Well, the records are what is going to help create change. I think by bringing public awareness to the thinking behind the sales and marketing strategies, why they were using these images of, you can't be a man unless you have an AR-15, and how they were targeting people. This is what's going to create change. And when I mean change, I mean their business practices. It's not going to stop the manufacturer of firearms. That wasn't the purpose of this lawsuit. It was to ensure that they were more accountable and responsible for the way that they were marketing these products, because we need to be thinking about safety when we're talking about who are marketing and who's buying these firearms.
All right, that's a major precedent and huge story about Remington being held responsible, or settling at least in that case. Now let's jump to yet another story. Here is the Vice President of the United States, the first female president, the first black vice president, I should say. And here she is talking about Black History Month yesterday.
This Black History Month, let all of us recommit to learn American history in full. Let each of us resolve to teach our children this history. History helps us to remember, it helps us to celebrate, and it helps us to aspire. It is dynamic, and it is something we all create every day. So as we mark Black History Month, let us rededicate ourselves to the fight for freedom, justice, and opportunity for all.
And President Biden also had something to say about Black History Month. Here is a short clip of that.
Black History Month is more than a celebration. It's a powerful reminder that Black history is American history. Black culture is American culture. Black stories are essential to the ongoing story of America. Shining a light on Black history is as important to understanding ourselves and growing stronger as a nation as it has ever been. And it's critical. So it's critical that we take the time to celebrate the contributions of Black Americans, honors the legacy of generations past, reckons with centuries of injustice, and confronts injustice that still festers today. Since taking office, Vice President Harris and I have been proud to build a government that looks like America. With trailblazing Black leaders in my cabinet and distinguished Black Americans serving in roles all across our administration. Very soon, I'll be honored to nominate the first Black woman in American history to serve on the United States Supreme Court.
Yes, and we're looking forward to that news and that announcement later on this week. And let's see, what else have I got for you? Oh, this idiot. This is the tennis player, this guy, this Novak Djokovic, whatever his name is. He was interviewed by a BBC reporter named Amal Rajan, and, well, I think it's pretty self-explanatory. Here you go.
I understand the consequences of my decision. And one of the consequences of my decision was not going to Australia, and I was prepared not to go. And I understand that not being vaccinated today, I'm unable to travel to most of the tournaments at the moment.
And that's the price you're willing to pay?
That is the price that I'm willing to pay.
Ultimately, are you prepared to forego the chance to be the greatest player that ever picked up a racket, statistically, because you feel so strongly about this jab?
Yes. I do.
Because you feel so strongly about this jab. Well, he wouldn't be the greatest tennis player ever to pick up the racket because I think that would have to go to Serena Williams. A lot of people were mentioning that. One might also argue statistics do not necessarily make the player. And here's an even better question. I saw someone on Twitter write, are you prepared to live with the fact that it's almost inevitable that your stature and very public stance has influenced at least one other person to follow you and that such likely resulted in death? Are you prepared for that? I thought that was a really good answer. You could ask that of any of the prominent folks, athletes, commentators, Aaron Rodgers, Joe Rogan, or anybody else who is selling this horseshit to people, who has the access to the greatest physicians and scientists in the world, and yet is still carrying on with this nonsense. All right, here's another good clip. I thought this was some good commentary from Charlie Sykes on MSNBC yesterday with Nicole Wallace talking about the Trump administration, its criminality, comparing it to what happened with the Nixon administration. Thought this was good and wanted to share it with you.
You imagine what Trump 2.0 would be, the revenge tour. Once Donald Trump actually learns how to use the levers of power, the question is, will there be checks and balances? And I thought the comment of your previous guest was very interesting, where he was talking about Watergate and the lesson that we thought that we had learned, that the president was not above the law. The president would be held accountable. But, just think about it, that there were, I think, 40 Nixon administration officials who were indicted and or imprisoned as a result of Watergate. Think of all of the criminal charges, all of the people who were held responsible. A president who was forced to resign, an attorney general who went to prison, a White House counsel who went to prison. And then in contrast that to what we have right now, where there are no consequences, no legal consequences whatsoever for what Donald Trump did, what he attempted to do, all the lies that he has told. And there's really very little prospect that there will be going forward. So there's a rather dramatic contrast between what we thought this country stood for in terms of the rule of law and the president and where we are right now.
All right. Well, there you go. Good commentary from Charlie Sykes. As ominous and kind of depressing as it was, I thought I'd throw that on for you as well. Now I got to get to a whole bunch of other headlines here and what we call the news dump. Rapid fire headlines with a brand new jingle from the great Pete Coe.
Dairy cows needing shots, time to line them up. They're inoculated by robots on today's news dump.
What is this? Oh, excuse me, cow. Excuse me, a robotic farmhand that is inoculating dairy cows. Yeah, that is the story that Pico is referring to, that apparently a dairy cow is inoculated by a robot and some kind of needleless injection. Okay. Thank you, Pete Coe. Let's get to some other really important news stories, headlines. 3G networks are shutting down soon, and there's a scramble to get users to upgrade. And that's apparently going to be an issue from your car to some other kind of device that only runs on 3G. Apparently, wireless companies who have moved to 4G and more recently 5G are trying to explain that the technology is going to become obsolete and hope that they can give consumers alternatives to avoid the disruption. So if you got a Kindle or a flip phone or the iPhone 5 and older models, various Android phones and some other wearable devices, including other, maybe a home alarm system, medical devices like fall detectors, honey, I've fallen, I can't get up, those kinds of things. You got your in-car crash notifications, roadside assistance systems like OnStar, all need to be updated or replaced. Read more all about it pretty much everywhere. Mentioned the Sandy Hook families are settling with Remington. This is the first time a gun maker has been held liable for a mass shooting. Major story there, of course. Also saw this. U.S. casinos won $53 billion in 2021. Their best year ever. Did you hear me? Casinos had their best year ever in 2021. America's commercial casinos. $53 billion, according to figures released on Tuesday. Did you contribute to that? Did you benefit from that? I guess congratulations. No congratulations in order to a Massachusetts preschool who are apologizing after they had a classroom full of toddlers who painted black faces on paper plates, then held them up to their own faces as a celebration of Black History Month. Oh, dear ski. The school said its director was away at the time, took immediate action when a parent brought it to her attention. Management said that because the news of the incident had circulated on social media, possible protests at the school could put children at risk, and it's a whole big mess. If the school does reopen, they're pledging to hold diversity training and hire a more diverse staff. Oh, man, that's a really big mistake by that classroom, that teacher. Here's an interesting new study I'm not sure I needed a new study for. Kids are using screens more than recommended. Too much screen time can lead to long-term issues, according to the research from the American Academy of Pediatrics, who says the majority of children under age 5 are getting more screen time than is recommended. Toddlers up to age 2 should avoid screen time other than video chatting, while children ages 2 to 5 should be limited to no more than 1 hour per day of high-quality programming. So to that lady who had her kid walking down the grocery store aisle with a phone in front of her face, not good. Let her look at the things in the aisle. There's plenty to see, and take off the aisle and annoy mom with. I mean, that one really shocked me. I think that was yesterday that I saw that lady doing that, or that kid doing that, just walking down the grocery store aisle, really, with the phone in your face? All right, what else do I tell you? How about this one? The U.S. sea levels are set to rise rapidly in the next 30 years, according to a new report. That's right. Sea level will rise as much in the next 30 years as it did in the past 100, increasing the frequency of high tide flooding, pushing storm surge to the extreme, and inundating vulnerable coastal infrastructure with salt water. So looking forward to the future there. Let's talk about one more or a few more stories. Prince Andrew is settling a sex abuse lawsuit with a woman who says he was trafficked to him by Jeffrey Epstein. I guess he borrowed $12 million from his mommy. Is that what I'm hearing? That Prince Andrew borrowed money from the Queen and paid this woman off in the settlement? Yikes. Arizona Senate passed a 15-week abortion ban. Make sure we pay attention to what's going on there and every other state, reeling back women's reproductive rights. A new study is casting doubt on ethanol's climate benefits. How about that? No surprise there. Scientists, this is good news, say the first woman apparently cured of HIV with new treatment. Major news. This is being reported by a number of news outlets, including NBC. Scientists expect to expand the eligibility of the state-of-the-art treatment to dozens more people every year. The treatment used stem cells from umbilical cord blood, which is more widely available than adult stem cells used in bone marrow transplants, according to the New York Times. A federal agency is going to allow advanced headlights after a petition from Toyota. Apparently, the National Highway Traffic Safety Administration is now permitting automakers to install adaptive driving beam headlights, or smart headlights, on new vehicles almost 10 years after Toyota petitioned the agency to allow the technology. Apparently, these are the ones that work by automatically adjusting beams so that oncoming drivers aren't affected by the glare. Do you like those? I like those. I've got those on my Honda CR-V. The smart headlights. I think I do, right? Am I using those? Are you using those? Is this a good idea? And finally, in today's news dump, sad news, a stand-up with Pete Dominic, semi-regular. I mean, I interviewed him a few times. Journalist, author, and commentator known for his political cracks and satirical witticisms, P.J. O'Rourke has passed away at the age of 74. Sad news. I really like that guy. I like talking to him. I certainly didn't always agree with him, but I liked reading him, and I liked talking to him. He was always nice to us, and I'm sorry to hear that he passed away. Appearing on CBS in 2010 ahead of the release of his new book, Don't Vote, It Just Encourages the Bastards, P.J. O'Rourke reflected on American politics, something he came to both embrace and criticize with good humor throughout his life and the direction it was headed. He wrote, "We're making politics part of everything. I've been writing about politics for 40 years, and what do you expect? I sort of feel like I'm the guy that cleans up the elephant house, and I'm not shocked at what I have to clean up." Well, there you go. P.J. O'Rourke, gone at age 74. And that is today's news dump. All right. Well, coming up, I talk about the opioid epidemic with a brand new guest here on the show. Dr. Andrew Kolodny joins me for the first time. But right now, I've got Dr. Aaron Carroll on the show, and it's always a great show when Aaron joins us. I mean, he really is one of the best guests you could ever imagine. And so anytime he's on the show, get a lot of listeners. Very excited to have him. He's one of my closest friends. He's going to be in New York with his wife this week, but over the years we've become really good friends. And today we talked about two of his most recent New York Times columnists. Of course, Aaron is a distinguished professor of pediatrics, and he's now the chief health officer at Indiana University. Check him out on Twitter at Aaron E. Carroll, and subscribe to his YouTube channel and now the podcast, Healthcare Triage, and you will know so much more about everything from exercise to nutrition to medicine to health insurance to so much more. I caught up with Aaron yesterday, and it was as great as always. Here we go with a jingle from Gareth Sever. Actually, a collaboration with Gareth and Pete Coe on the vocals. Love to see it. Here we go.
Dr. Carroll.
Aaron Carroll. He's Karen, and he shares it all. Aaron Carroll. He's blaring it out and bears it all.
He knows modern medicine, dispels disinformation. He's a brilliant pediatrician. All that and then some. Aaron Carroll. He's the IUCHO, does HSR, writes NYTO, and puts out HC triage.
Dr. Carroll. Dr. Carroll, to the
Very
head of
little
you.
excites me, but very few people are more excited. Am I more excited to talk to on the show, but also to see in person? And you are going to be coming to New York. Dr. Aaron Carroll, welcome back to the show. More importantly, I'm very excited to see you. Very excited.
I'm excited to see you too, and I'm horrified that you started this show by saying very little excites me.
Very little excites me. People, I don't know why I said that. I get excited to see people. I love a lot of people, but you're one of my favorite people to hang out with, and I don't get to see you. And mostly we've been talking about, on the record, not enough off, just on our own. And you've obviously had a year. I've had a year, not as bad as your year, not even remotely close. You've shared that with us on the last time you were on, I think. But anyway, I'm just super excited to see you and spend some time with you, and even more importantly, your wife.
Absolutely.
Yes.
Likewise.
You like New York.
I do. I love it. It's great.
But just to visit.
Well, first of all, like my job's not there, and
Right.
it's easier to have a house in Indiana.
Well, that's for sure. You certainly. How about this for a segue? You certainly like the New York Times, where you have been published yet again.
I literally thought you said the New York Dives at first, and I'm like, I usually eat in pretty nice restaurants. But no.
When was the last time you went into a dive, even for any reason?
I do all the time. But like, if I'm coming to New York,
Right.
I'm not. I'm coming to eat.
Oh, okay, so you'll go in and you'll have
Oh yeah. Yeah, I'm not a food snob, but like when we come to New York, like I want to eat
Sure,
in
fair
fancy
enough.
restaurants.
But no, you've been published in the New York Times many, many times. Of course, you're a contributor there, and you've got a recent op-ed that I wanted to talk with you about. It's super important. COVID drugs may work well, but our health system doesn't. You've written this article 100 different ways and used different situations to explain why our healthcare system is broken. In this case, it's not where the vaccines that we're talking about, or particularly the tests or anything else necessarily. It's about the treatments that are now available. They're good treatments, but there's some problems with them. But unfortunately, a lot of people that need them can't access them because of our health system hates us.
Yeah. Well, I mean, I don't think the health system's alive to hate us, but if it were alive, it would appear to hate us. Yes.
And you illustrate it really well here. But first of all, just how big a deal are these treatments? And we would prefer that everybody get vaccinated and boosted, but in lieu of it, or in addition to it?
It's not even in lieu of it. It's just that, first of all, there are people who vaccines won't work on. They're immunocompromised, or they're in very high risk, or for some medical reason, they aren't able to get them. And so it behooves us to have therapies for them. There are some people also who aren't vaccinated for a variety of reasons, and the treatments will work for them. And then there's some people who are vaccinated, but they're still at risk, and they get sick. And it's also great to have treatments to reduce their chance of hospitalization and death. And some of these therapies are great. They reduce hospitalization and death like 85, almost 90%. That's huge. But you got to get these drugs in 5 days. And it feels like everything in the healthcare system is trying to prevent that from happening.
Yeah, it's there's so many different elements of the healthcare system that are trying to prevent that from happening. But take an example you want of somebody who might be vulnerable, who might have some symptoms, might not have the best health insurance, might not have the best resources, but they know they decide they want to get tested. What happens next for this person?
Well, like, first of all, like you have symptoms, you need to get tested.
Yep.
You're if there's a surge going on, good luck getting an appointment. It could be days out. So there's time wasted. I guess you could use an antigen test. Those fill up even faster when times are not. Maybe you've got a couple in the house. The Biden administration has been willing to send you your household 4 of them. But, okay, so let's say you've gotten one. Well, now you've got the results, but just because you're positive, you can't just go get the drug. You got to get a prescription. Prescription often requires a doctor's visit. Half people in the United States couldn't get a same day or next day appointment when they were sick before the pandemic. Trying to get one now, it can take a couple days. And then, okay, you got a prescription. But where are you going to get it filled? A lot of the pharmacies are back ordered or out of the medication, and it's not easy to get. It's unclear. And each of those small delays adds up where if you don't get this thing started within 5 days of infection, it doesn't work. And so why, it's just not set up to help people get what they need when they need it.
And that's not the case in other countries that are doing it better, right? I mean, that is kind of the difference that I think is most interesting to readers and to listeners right now, that this is always about the U.S. healthcare system, which you have written over and over, is not, I repeat and repeat over, the best in the world.
No. I mean, first of all, it's much easier to get a test in many other countries. In fact, they've been giving out antigen tests in many countries since the beginning of this, where tests are everywhere. And the reason that we need a prescription for this is because that's how the American healthcare system works. I mean, there's no reason why, other than the fact that we're not going to do it. We couldn't say to pharmacists, hey, when you're seeing, or when people come into the pharmacy, ask them a couple questions, figure out if they're at high risk. If they are, give them a pill pack. Tell them, don't take this unless you're told to, or else you have COVID. But we can make it so that everyone who's at high risk has a pack in the house.
Just like the EpiPen, you said.
Exactly. We could do it like that, make it preventive, which is what it is. And so people would have it. And if they need it, fine, crack it open and use it. And then we can make it easy to get tests. We can make all of this easy. We make none of it easy. And, at the moment, costs aren't the biggest thing. But of course, for every other thing in the world, costs come into play as well. It's, you have to find the right pharmacy because it's got to be in your plan, and you got to go to the right doctor, and you got to, none of this is set up to do what we really need to do, which is get people who are going to need these therapies the ability to take them as quickly as possible once they're sick.
There's an issue here with physicians versus pharmacists, not only here, but in other cases too, right?
Yeah, I mean, before the pandemic, pharmacists weren't even allowed to give out vaccinations to kids.
What?
No, yeah, they had to change regulations, I think, to let pharmacists give immunizations to kids. Before this, no. You couldn't get a flu shot for a kid at a pharmacy.
Could you get a prescription for a flu shot?
Well, you could go to your doctor, but remember, doctors have been trying forever to keep minute clinics and other things. They don't want you to go anywhere else for healthcare. And, I'm saying this sort of flip, but lots of regulations and stuff make it very difficult to do stuff without going to a doctor's office. I mean, right. Look, home pregnancy, there's very few things we can test for at home. COVID, we now can. Think of what else can we do? Pregnancy is one of the few other things we can do. Doctors fought that tooth and nail. You can find amazing op-eds saying that it's dangerous to allow women to find out if they are pregnant without a doctor's.
Why? Really? Why? Why would that?
Because we don't want care to happen out of the home. Out of the office. And so they would make arguments that the women, they can make mistakes and they can make bad decisions if they don't get the right exact data and they aren't counseled or not. This isn't. Finally, a judge was pregnancy is not a disease.
Well, they would make mistakes and bad decisions more likely if they didn't have the data that they were pregnant. For example, drinking or doing something risky or any number of other things, planning out their fucking life. Getting an abortion now. You
can find links. You can easily find links.
Wow.
Doctors writing editorials saying that it's dangerous to have home pregnancy tests, that they're not good enough, that we need to do these things in the clinical setting. There's so many things we could theoretically diagnose at home. We do none of that. We just don't allow this stuff because we, meaning the healthcare system, wants the healthcare system to work the way that it is set up right now. And unfortunately, the way it's set up right now is often crap.
Yeah, you're right. Too few people understand that much of the U.S. healthcare system is set up to make it harder for people to get care, an attempt to drive down overall healthcare spending. For example,
the overall push of conservative, and I mean that with a lowercase c, healthcare reform in the last decade or two has been people don't have enough skin in the game. We need to make them better consumers. We need to make them pay more out of pocket, high deductible health plans, so that they'll think twice about going to get care, and that first they'll have to spend their money before they spend insurance money, because the reason the healthcare costs so much in the United States is because people just want too much of it. Well, okay, people have gotten what they want. Our deductibles have gone through the roof.
Right.
Most people have thousands of dollars in deductibles, which makes it much harder to get care. They all just reset on January 1, which makes no sense, because why in the middle of even flu season would you do that? But we were right in the middle of Omicron, and that's when the deductibles re-kick in. Now, granted, most COVID care at this point is just free. I mean, we're not charging for vaccines. We're not charging for like going to get COVID tests if you can go get them. And I'm sure that they're paying for the drugs as well. But when you think about it, we have set up a system which is designed on the idea that people are too free spending willy-nilly, that we need to make them think twice before they go get care.
Which there's no real data or research for here or anywhere else, because if you've taught us many times.
This is where I'll push back. The RAND health insurance experiment, which granted is decades old at this point, was a big randomized controlled trial that randomized mostly white employed people in Colorado, if I remember correctly, they were randomized to one of a variety of health plans, which went from no deductible to almost an enormous deductible. And they found, yeah, it's true. If you get people to spend their own money, they consume less healthcare. And if they're healthy and they consume less healthcare, they don't get hurt, which is great. And most employed white people in Colorado in the study were pretty healthy. But, sub-analyses also showed that if you were poorer and had high risks, like, I don't remember, hypertension or heart disease, you actually had excess mortality. More people died because people are terrible discriminators between necessary and unnecessary care. When you make people pay with their own money, they spend less. Unfortunately, sick people die. And that's what you got to remember here, is that we're talking about sick people. They don't need to be incentivized away from care. We want to incentivize them to care.
I thought you've talked many times about how healthcare markets don't work like most other markets. People don't get excited about going to get a mammogram or a colonoscopy. They're not all excited to use their insurance.
No, it's the people always talk about it, the example people always give is steak insurance, that if we gave people really good steak insurance, everyone would want filet and no one would want sirloin. Yeah, but no one wants an appendectomy. Nobody wants an extra colonoscopy, or more chemo. They just want what they need. So what we're talking about when we talk about that is healthy people who are, basically consuming care they don't need, extra MRI. Yeah, that exists, but we aren't good. We use cost sharing like a club. It needs to be a scalpel. We need to incentivize healthy people away from stuff they don't need. But at the same time, we need to incentivize sick people to the stuff we need. But deductibles do none of that. Deductibles say, I don't care if it's life-saving care or nothing burgers. You have to pay out of pocket, and we want you to get none of it.
Let me ask you about this other piece that you recently published for New York Times titled, "To Fight COVID, We Need to Think Less Like Doctors." How dare you go after physicians and the way that they think? What is it that doctors have wrong?
So doctors, if you have COVID, you want a doctor. There's no question. You are sick with COVID. You probably want an infectious disease specialist. You want someone who's focused on you, who's thinking of you first, who, wants the best for you. Nothing else will do. That's what you want. But America's not a patient. And we are allowing too often physicians and physician viewpoints to dictate broad population-based policy. And I think that that's taken us in the wrong direction multiple times. I gave an example in Indiana. We were running out of antigen tests. And so our ISDH, the Department of Health, decided, okay, we're going to only let antigen tests be used in our settings for elderly at-risk patients or kids. We're not going to let adults from 19 to, 55, let's say, I can't remember, 55 or 60, get an antigen test because they're at lower risk.
The state, therefore, chose not to use them all for adults ages 19 to 49. Instead, they prioritized those 50 and above as well as children patients.
Their argument is that those are the highest risk people, and therefore we should focus the tests on them. And from a doctor's viewpoint, this makes total sense. This patient's why would I want to give a test to a low risk patient? I want to give them to the high risk patient. But from a population public health standpoint, that's exactly the wrong way to think about this. Old people don't need to know if they have COVID fast. You don't prevent COVID with by getting the test fast. What prevents COVID is if a young person finds out that they're sick before they go out amongst other people. That's how you prevent COVID, by giving the test to the younger, healthier people, not the higher at-risk people. And that probably makes no intuitive sense when you think about the individual, but from a population, you got to do things differently. An individual, you're like, you need the best COVID test. You need the best, nothing else will do, the best mask. Your N95s are scarce, so you better not wear a mask. And, you can only have a high quality PCR, even if I can only do a couple of hundred of those a day. And it's like, that's how you treat individuals. But for a population level, I'd rather at the beginning of the pandemic have everybody in a crappy mask than to have a few people in a great mask. And I'd rather have tons of people getting slightly less high quality tests like antigen tests than to have few people get a perfect test. And yet, again and again, physicians are, and the clinical mindset is how this response has been run. If you think about it, we always hear from physicians, and I'm one, so don't get me wrong, I understand.
But physicians hate you because you're critical of them.
But I'm also like, I don't practice much individual medicine. These days, I'm much more, about population, and that's just my focus. And I do think that we have that those who are leading our response and those who have been in charge of it often are really taking a clinical, individual mindset, which physicians should do. Don't get me wrong, when they're taking care of patients. It's not that it's wrong, it's just misplaced. And you can't do that. Like, we need more public health mindset for dealing with this off.
You also write there's not just doctors in this article who focus on individual risk. It's also patients. For example, parents might reason that the risk to their child from COVID and other vaccine preventable diseases in the U.S. is very low. So why take any risk of a vaccine at all?
So I wrote a piece years ago about the flu shot that literally could have been rewritten for COVID. And if I remember correctly, the title was like, well, first of all, it's not about you. Like, I get, even with flu, I've gotten this for years from patients who are like, flu's not that much of a risk for me, so why should I get it? Why should I take on any risk at all from a vaccine if there's very little risk of me, even if I get the disease? And first of all, I'd say, like, well, there is risk from the disease, so you're doing that. And the risk from the vaccine is very small, but it's not about you. Like, a big reason to get vaccinated is to protect others that you love, those who can't protect themselves. With flu, it's the elderly, it's the very young, it's the immunocompromised, it's your friends and loved ones who might have cancer or some other, immunocompromising syndrome. That's why you get vaccinated. But we keep trying to convince everyone to take the flu, even the COVID shot, by trying to say, like, oh, but your risk of death goes down. But that won't work on people who are at low risk. Like, what we should be saying is, like, yeah, we all need to get vaccinated to protect the people we love who can't protect themselves. Do you have an old elderly parent? Do you not like them? Like, do you know anyone in your life who might be sick or obese, or, pick any other, chronic illness which might make you more likely to get sick and, or God forbid, die from COVID? Get vaccinated for them. Like, that's why we need to vaccinate kids, is to protect their grandparents and to protect their babies, their siblings who are we don't do that. Right. We keep doing individual.
Let me ask you about the mask thing. Is this the most annoying question for you to weigh in on, the masks in schools thing?
No, I mean, first of all, this is my job at this point. So
I know, but well, first of all, just real quick, is there any evidence that the masks are dangerous for kids or adults to wear in terms of?
Well, you know what? This is where it's like, you're asking me, like, to answer in a binary. I say this all the time, like, safety's not binary. These questions can't be answered in a binary way. Can you just say, like, is it dangerous to wear a mask? What do you mean? Like, are they going to die?
Well, we had a
are there downsides to wearing a mask? Yes.
At the BOE meeting, a 13-year-old kid came up to the microphone, complaining about having to wear a mask. His parents clearly put him up to it. And he said he's breathing his own poison and it's making him sick or something like that.
Well, you're not breathing your own poison. It's not making you sick. But having said that, it is a pain in the ass.
Yes.
My glasses fog up continuously.
Yes.
I can't see other people in meetings. I imagine as a child, not being able to see the blackboard is a problem. I also think it's harder to hear people, and it's, people, you can't read facial expressions, and that's very hard for me. It's hard for me to have conversations because I need the facial cues in order to have decent conversation. So there are downsides, and there is, there is probably some benefit, but let's not overstate the known benefit from universal masking of kids in classrooms. I don't know how much added value there is on top of stay in your seat, face forward. Let's not, do stuff. Most kids were not getting COVID at school. They were getting COVID and all the things they don't do at school. School may be one of the safest times that many kids spend. So my problem with this is that we're catastrophizing both sides. The masks are going to kill you. And, oh my gosh, if they're not masked up, we're exposing them to so much danger. Right. When we're talking about two areas of gray, and I mean, to say there's no evidence is ridiculous. It's this is an airborne illness. Masking is better than not masking. But I don't know the specific amount of benefit that we're getting, especially once we get through the surge here, which is happening pretty fast. So this is not an area I'd go down. This is not a hill I'm going to die on. If people want to start pulling back on masks now that we've got a breather, and more kids can get vaccinated, I don't think that that's a hill that I would die on.
What about, where are we? That's what I was going to ask you.
We're coming down fast. I mean, even in Indiana, it's plummeting. Now, it's still high. I don't think we're out of the woods yet, but, hospitalization's coming down. Everything's coming down. I can tell you our numbers on campus are way down.
Yeah.
And, we have to give people, look, I work at a university where we've got a 90-some% plus. I think I'm Bloomington, 95% vaccinated, very few cases, ubiquitous testing. Everybody's done what we've asked them over and over and over again. I think as it cools down and gets low, we ratchet back some of the restrictions because everyone's done everything we've asked to be safe. And people always say, oh, but if you ratchet them back, then people won't put them back on. And I'm like, everyone has done everything we've asked and more to keep each other safe during the pandemic. To say now that I don't trust them is somewhat ridiculous. When things get lighter, we have to be able to do less.
I follow and interview a lot of infectious disease experts nowadays, and you are better at all of that than most people are. So what do you see in terms of a potential variant? I mean, that's what everybody's just ready for the next variant. We're not out of the woods yet.
There's no way to tell.
Right.
I mean, we thought after Delta, everyone was fingers crossed. Yeah. And the beginning of November, we're all oh, looks like we're getting out of this. And then 3 weeks later, it's the first time we heard of Omicron. And then a couple weeks later, it was everywhere in the United States. We had no lead time at all. Right. It was literally from the moment we heard about Omicron till it was here was less than a month. So I don't know. Tomorrow we could hear about a new variant. A month later, it could be a surge. I hope not.
How good is that? How good is that wastewater testing?
Well, it's good for tracking, but it's if you have ubiquitous testing, you don't need the wastewater. You need the wastewater if people are not getting tested and you don't know what's going on. So people would ask all the time, why aren't you using wastewater at IU? I'm we were testing tons and tons and tons of people. I don't need wastewater when I'm testing huge.
But wouldn't it be more efficient because everybody's in? Everybody is taking dumps, and so if it's not expensive,
again, it's you still need the rest of it. That might be an early warning sign, but it's it's not what are you going to do when you find it? If you're going to be ooh, there it is.
Make an announcement that it's here. It's about to. Is it too late?
Is there anyone in the United States that didn't know Omicron's here? I mean, could you possibly not know?
I don't know why. I thought that.
What else would we have gained?
Yeah.
2 more weeks of people doing, with the government going, I don't have any tests for you, and people would what will we do? Unless we're willing to say oh, we've got wastewater, and then we're going to take these steps. What's the point of finding out early?
Hey, what's the deal with the super vaccine? The vaccine to kill all vaccines.
No, what was that?
There's a vaccine that's good for all the variants and that's going to be good forever or something. A perfect vaccine.
Okay, first of all, good forever, I don't know. But
perfect vaccine.
The ones we have been good against all the variants.
Yeah.
Moderna and Pfizer, great, go get them.
So you don't think we need a newer, better, more?
Not yet. We might at some point in the future. Yeah. And if they want to make one that's even better against Omicron, so be it. But the vaccines that we have, when you're properly boosted, have been spectacularly good against all the variants.
Anybody else have any questions? Just me, actually, in the shed. Let me just ask you before I let you go. You've been consistently continuing to publish at your amazing award-winning YouTube channel, which, if folks haven't checked out, they suck. It's called Healthcare Triage with Dr. Aaron Carroll, and I'm very excited to watch this latest video. I haven't watched it yet. I just thought to ask you about this. It's called Encouraging Exercise, the Mega Study. Of course, you're the author of the Bad Food Bible. You're the best at researching the research. The Mega Study is a study of all the studies, right?
It was like, no. This was like, you should watch the video because I don't have enough time to explain it fully. Right. It was like a huge study where they randomized people to all different kinds of interventions to see if they could exercise more. But more importantly, I just realized by the time this drops, we are launching a brand new podcast, which I think the first few episodes drop Wednesday of this week, which is tomorrow. I don't know when this will air, but you should go check that out. We're doing an 8-part series on like what's wrong with the culture of science. We interviewed experts from all over the country, and I'm super duper proud of it. And it's, I think the first 3 episodes will drop tomorrow.
Wait, what's it called for people to find it?
It's Healthcare Triage Podcast.
Yes.
But it's just like, it's its own contained 8-part series, but go to the Healthcare Triage Podcast.
That is excellent. Congratulations. I'm sorry I didn't know that ahead of time. I guess I'm not in the know. 8-part series, what's wrong with the culture of...
I think it's what's wrong with the culture of science, and how does that have to do with like why research is not reproducible?
So that's awesome. I can't wait to.
Yeah, you should listen. It's really, really good.
Yeah, for sure. Yeah. Congratulations on that, and to your colleagues on that as well. All right. So if people want to know about exercise, they'll have to watch the video. That's what
watch the video.
But we should exercise, right? Don't tell me you're gonna.
Yes. Oh my God. Yes. This is about how do we get more people to exercise, with incentives.
Okay. All right. Well, thank you very much for your time, as always. I greatly appreciate it. I can't wait to see you in just a few days in person. Yes. It's going to be the first time in a long time, and I'm going to give you a hug that's going to last too long.
Sweet. Can't wait.
All right, buddy.
See you soon.
All right, there he goes. Aaron E. Carroll on Twitter, Healthcare Triage on YouTube, and look for and subscribe to the podcast. And look for my picture with Aaron this weekend. When I see him, I think I'm going to see him on Saturday. Really looking forward to seeing him and Amy. All right, well, there's been so many headlines lately about opioids and the opioid epidemic and settlements and needle exchanges and fentanyl and so much more. So I've been wanting to talk about this with someone who really knew what they were talking about, and I found the best guest and really prepared hard for it. I think you'll be able to tell I worked hard on this one. Also, he is also a chief medical officer. How about that? He is the medical director of opioid policy research at the Heller School for Social Policy and Management at Brandeis University. And he mostly focuses on opioid and heroin crisis that devastates families and communities across the country. Also the executive director of an interesting organization called Physicians for Responsible Opioid Prescribing, whose mission it is to reduce morbidity and mortality caused by overprescribing of opioids. And he is got a whole bunch of degrees. I'm very excited to have him joining me for the first time on the show. I think we had an amazing and really important conversation that you're going to learn a lot from. Here he is, Dr. Andrew Kolodny. Would love for you to check him out, by the way, on Twitter and let him know that you heard him here. He's on Twitter at Andrew Kolodny, Kolodny, and here we go.
Recording in progress.
There she is. All right, well, I've got him now. I've just told you all about him. Dr. Andrew Kolodny, thank you very much for joining me from, I suspect, from Massachusetts, although you don't have to tell us where you are.
Okay, that sounds good.
Because this is, I guess, a controversial subject, but you are one of the foremost experts on all of it and can comment on so much of it. But let's start with, I think it's important, you were just telling me, the kind of epidemiology of the epidemic as it is right now. Who is affected, where they're affected, and why they're affected here in 2022. I've just listed some of the statistics. 100,000 people dying of overdoses this year. Much of that, drug overdoses, much of that is because of opioids. We can break that down, but I know that your work from my research says it's getting worse. It's trending worse every year. The numbers are up. So where are we at with the epidemiology of it?
Yeah, so that's a great place to start. We have, roughly speaking, 3 groups of opioid-addicted Americans. And when you talk about the overdose deaths, it's really important to recognize that the vast majority of the deaths occur in people who are addicted. It's not people who deciding that, hey, injecting fentanyl would be a fun way to spend a Friday night. These are people who've had addiction, and not everyone who dies of an opioid overdose was addicted, but the vast majority of the deaths are in people who were addicted. So roughly we have three groups of opioid addicted Americans. We have two groups that were affected during the current epidemic, and then an older group that became opioid addicted in the 1970s and 80s, which tends to get less attention. So of these three groups, there's an older, non-white, disproportionately Black and Latino group of Americans who became opioid addicted in the 70s, who their addiction began with heroin. They didn't switch to heroin from prescription opioids. And these are mostly men who managed to beat the odds for 40, 50 years despite their heroin addiction. These are men who've seen many of their friends die of overdoses. They've seen many of their friends die of AIDS because when HIV hit, it killed many injection drug users. And this is a group that is dying at a very high rate right now because the heroin supply has become so dangerous because there's fentanyl in it. So that's the first group, older, disproportionately Black and Latino, longtime heroin users. Then we have these other two groups that became opioid addicted post-1996. And it's basically a younger group and an older group. The younger group are people in their 20s, 30s, and 40s who switched to heroin after becoming addicted to prescription opioids. And the older group there are people who really haven't been switching to heroin that much. They've mostly been sticking with the prescription opioid. So those are roughly speaking the three different groups up until around 2012, 2013. When you looked at where we had the most deaths, it was in this older white group that gets pills more easily from doctors, the group that wasn't switching to heroin. After around 2014, when the heroin supply became extremely dangerous, deaths in heroin users began to skyrocket. So the older non-white group and the younger white group caught up and then surpassed this middle-aged and older white group that was dying from prescription opioids.
Not only caught up and surpassed, but in huge numbers, right? When you talk about surpassing, you can look at every state on the map change with their statistics, and that is because of the overprescription issue, right?
So the overprescribing, which really takes off in around 1996, that's what caused the new epidemic. So the people who became opioid addicted post-1996, overwhelmingly, their addiction began with prescription opioids. The younger people who became addicted would switch to heroin because if you're young and you're addicted to the pills, it's hard to find doctors who are going to give you enough pills every month. Unless the doctor's a drug dealer, they don't want to give a healthy-looking 25-year-old a large quantity of pills every month for pain. So that younger group wound up on the black market because they had a harder time getting pills from doctors. The pills are very expensive on the black market, so they've been switching to heroin for the past 20 years.
I guess the reason why this is also important, why you lay it out this way, is because it's difficult for journalists or people like myself to try to understand these different categories, but it's important for someone like you to explain them because the interventions needed, the policies that would apply to helping solve this problem are probably different for each population based on how they came in contact first with it and how they sustain their usage of it. Is that what I'm getting?
Absolutely. The opioid crisis is best understood as an epidemic of people with addiction, meaning the reason we have all of these deaths and the reason we've seen fentanyl flood into non-urban areas, the reason we've seen a soaring increase in infants born opioid dependent, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems has been an increase in the number of people with the disease of opioid addiction. And if you're going to respond to this disease epidemic, you really have to understand the populations that are affected. to try and tackle this problem without framing it the way that I just have and without understanding the epidemiology would be like trying to respond to COVID without knowing which geographic areas have higher hospitalization rates or higher deaths or higher positivity rates.
Gosh, it's so interesting it must be very frustrating and interesting to look at it from an epidemiology standpoint when you see COVID, which I'm going to go ahead and try to argue is a bit more straightforward, a respiratory virus in terms of it's going to affect everybody versus something like HIV, AIDS, or opioid addiction, which has so many more layers, social issues, I think, layer upon it as well. But you do compare all of them pretty equally. I mean, you talk about opioid addiction as a disease, just as HIV or just as COVID is. Is that fair to say?
It is fair to say, and I do think that the extent to which social or socioeconomic factors have influenced the crisis, I think have been overstated. And economists who've studied this issue to try and understand why do some geographic areas have a more severe opioid crisis than others, one of the arguments was made that it had something to do with downward mobility in middle-class Americans who were drugging themselves because of despair was the argument. Yeah. The economists who've studied this really haven't been able to find that economics really explains the geographic differences. The most consistent explanation for the geographic differences are that the epidemic is most severe in areas where opioids were prescribed more aggressively. And the reality is that just about anyone that's repeatedly exposed to an opioid can develop opioid addiction. It doesn't really, it's not like alcohol, opioids. With alcohol, most of the population can use alcohol repeatedly and doesn't develop addiction. And when you look at who gets addicted to alcohol, it tends to run in families. Opioids are more like nicotine. Just about anyone who's repeatedly exposed can become addicted.
I'm also proof that none of these things work because I've tried. It's not taking. I've been drinking far too much, but I don't seem to need it necessarily. And it's different for everybody, obviously. But you talk about it as a disease, but it's also, I think, interesting to discuss when it comes to opioids. Specifically, you've made this point, I think, several times in your work, the difference between how the epidemic is played out in other countries versus our country. And it seems to be, I'm sure there's plenty of factors, but that we have always overprescribed painkillers, whereas they haven't in other countries. And again, the difference is it's not the black market heroin that we're talking about. That's a different situation, how it gets there, supply and demand. But whether it's, I don't know, you can tell me the countries, the UK, Norway, or the US, number one, we advertise drugs, which I think is unique. Only country in the world, I think. But more importantly, the prescription rates are different. I've seen you come back to that point many times. Is that a good question for this point in our discussion?
Yes, absolutely. Just as the geographic differences in the United States can be explained by the supply of opioids in regions of the U.S. that have a more or less severe crisis, that applies internationally as well. And there is no other country on earth that comes even close to prescribing as much opioids or consuming as much prescription opioids as we do in the United States. And that is the reason that we have a severe epidemic of opioid addiction. When you overexpose a population to this highly addictive drug, many people will become addicted. Probably the next closest in terms of historical comparisons for addiction epidemics, the closest probably we've ever come in history to what the United States is dealing with today might be the opium smoking epidemic in China in the late 1800s. And what we're dealing with in the United States today is far more severe in terms of the mortality than what they were dealing with in China in the 1800s.
Should we? First of all, I found out right before we connected here, apparently you're a controversial guy. I had no idea. I had no idea there was some controversy or that there was some issue within a community of people, I guess, who deal with chronic pain, who think they need these drugs. And people like you are advocating that government create more guidelines on how they're prescribed. Talk to me about what your stance is on this, where the research is on this, because certainly you agree that the opioids can be prescribed for some people and in some cases, but there apparently is a huge community of people who really don't like your take on this, and a lot of the public health community, because obviously it's not just you. Help me understand that controversy.
Sure. I don't think that the things that I say are controversial.
Right.
The science behind the statements that I make about opioids are not controversial. The science is pretty clear about their risks and benefits. But to some extent, I have been controversialized, and the positions that myself and others who have advocated for more cautious prescribing of opioids, our positions have been made controversial, and in part by an industry that was interested in preserving the status quo. You can look at documents that have become unsealed, internal communications from the Sackler family and Purdue Pharma, where they identified an organization that I helped co-found as a financial threat to OxyContin sales. And they also identified a guideline from the CDC as a financial threat, and even did the math on how much it would cost if doctors in the United States followed the CDC guideline and took patients who were on the highest doses of OxyContin and put them on lower doses. And so, but I don't really believe that the things that I've been saying are genuinely.
I actually did know that and researched it well enough, and probably shouldn't have framed it that way. But you're basically what I think it seems like my friend Peter Hotez is to vaccines, or my friend Dr. Michael Mann is to climate science, where the science is settled, but you, as the expert, are made to be some controversial person because what you're saying, what you're recommending, what the science is saying is hitting them and their bottom line. It hurts their profits, and therefore they actually invest in a propaganda campaign to destroy not only you, but all of the research that you and others have done to make us question it. How am I doing?
You're absolutely right.
Okay.
In the case of opioids, this campaign was especially effective because we do have millions of Americans, maybe 10 million Americans, who have been put on long-term opioids for conditions where doctors today know better than to start long-term use of opioids, conditions like low back pain or fibromyalgia or chronic headache, where there's an expert consensus, don't get patients stuck on opioids for these conditions. Many of these patients, especially the ones who are on very high doses, are having a harder time finding doctors who will continue to prescribe in this very aggressive fashion. And some of these patients have tried to take themselves off of opioids and know that they can't because it's so difficult to come off. And some of these patients may also truly believe the opioids help them because before they take their first dose in the morning, they're feeling horrible pain. They take a dose, they feel relief. They can walk the dog, they can take a shower. They believe that the opioids allow them to function. What they don't recognize is the relief they're experiencing is the relief of the previous dose wearing off, the relief of the withdrawal pain.
Yeah, I think anybody who knows somebody who's gone through those withdrawals has learned just a little bit about how horrible it can be. So the campaign from several pharmaceutical companies, many of us have come to realize there's been a lot of great journalism and obviously now legal cases and settlements on several of these different companies. We hear about Purdue Pharma and the Sackler family, but there have been major lawsuits against and settled or won by against, I think, Johnson & Johnson. There's a company called Teva. So help me understand, it takes a little time to help us understand the history of these pharmaceutical companies. And, tell me at all if you think any of these settlements or legal cases have been game changers.
So, I'm glad you're asking about these other companies because I think that the Sackler family and Purdue Pharma tend to steal the spotlight. And certainly the opioid crisis would not have happened if it was just this one family that, through their greed, was willing to promote a highly addictive drug for conditions where we shouldn't use it. There were other drug companies that acted similarly. Johnson & Johnson, which tends to have this wholesome reputation for making baby powder and baby shampoo, and, actually was supplying Purdue Pharma with the opium that was necessary to make oxycodone. To make oxycodone, which is an OxyContin, you literally need to grow opium poppies, extract the opium, and convert that opium into a semi-synthetic opioid. And so the opium that was being imported into the United States was coming from a factory run by a Johnson & Johnson subsidiary, imported by a Johnson & Johnson subsidiary. And most actually of the opioid makers in the United States were buying their opioids from J&J. Meanwhile, J&J was also selling its own opioids, and like Purdue Pharma, disseminating messages to downplay the risks of opioids and exaggerate their benefits.
I always try to work in any mention of Native peoples, tribal folks, and just so the headline there on what you're talking about, hundreds of Native American tribes that have suffered disproportionately high addiction and death rates during the opioid epidemic agreed on Tuesday to a tentative settlement of $590 million with Johnson & Johnson and the country's three largest drug distributors. Together with the deal struck last fall between the distributors and the Cherokee Nation for $75 million, the tribe will be paid a total of $665 million. Purdue Pharma has already committed at least tens of millions more to the tribes in a settlement that is in mediation. Anything to say about how this has disproportionately affected Native Americans or anything else about the settlements, Doctor?
The opioid crisis has disproportionately affected Native Americans. Native Americans have been a population where there was aggressive opioid prescribing and where many Native Americans have become opioid addicted. Overall, I think that the litigation, I believe, is going to have a very positive public health impact, but not necessarily in the way that many people would automatically assume. I think that the money that comes from the judgments or settlements against the defendants in the opioid litigation will certainly be used for what are termed abatement strategies, interventions to expand access to treatment, interventions to directly address the crisis, which I think are obvious to people why they would be helpful. But the less obvious reason why I think the litigation is going to be helpful or potentially helpful is if the public gets to learn more about what actually happened behind the scenes. If you think about the impact of the litigation against big tobacco, yes, there was funding that came from the settlement against big tobacco for prevention of smoking, particularly in adolescents. But as the public learns from the big tobacco litigation, how big tobacco manipulated nicotine levels, targeted adolescents, lied about cancer, lied about addiction, all of that helped change attitudes in the United States around smoking. I think that the more that the American public learns about how opioid manufacturers and the front groups they work with and the doctors that were their spokespersons, as the public learns more about the ways in which they lied and managed to manipulate and influence medical practice to cause a crisis in the U.S., I think that could help change attitudes in the U.S. about popping an opioid pill every time you have a complaint of pain.
Yeah, that's a really, really important and great point. I wonder if there's any books, documentaries, articles, or journalists that you think have done a really good job kind of documented this. I remember Sam Quinones' book, Dreamland, The True Tale of America's Opioid Epidemic is really great, but I wonder if there's anything else that does. I mean, there's even TV series like the Dope Sick, I think. I don't know how well. I don't know anything about that series, but I'm not sure how well it does. But I mean, is there any reference for folks if they want to learn more about it?
Yeah. I'm looking over my left shoulder here because I'm in my office where I have
you know what,
Andrew? Books here.
I seriously, this might be too radical for you, but I've done this with a lot of other guests. You're the expert here. If you want to get a screen grab and send it, I'll include it in the show notes,
I'll do that.
And we'll have all those books as a reference. Let me just ask you quickly about the really important, not quickly, I guess, but however much time you want to take. Fentanyl. How is it a game changer? Is there what can government, if anything, do to prevent it? My understanding is it comes in from China a lot, and it's in pills, and it's really hard to detect. How has it changed the whole game, if it has, or is it being overstated?
It's not being overstated.
Okay.
The reason that we've seen deaths skyrocketing in the past few years, particularly in these groups, this group that switched to heroin from prescription opioids and this group of longtime heroin users, there's no question that fentanyl is the reason we're seeing the deaths just take off like nothing we had seen before. 100,000 deaths in a 12-month period, driven mainly by fentanyl. So it's not at all overstated.
And I just want to jump into kind of the reason where I always think, will people care about this conversation I'm having on today's episode, or will they be interested in it? And even though it doesn't necessarily directly affect them. But when I think about fentanyl, I think about a very wealthy friend of mine whose daughter died at 21 years old. And obviously you think about middle and lower income folks always being affected by this. But the point I'm trying to make is everybody listening could be, killed or have a loved one die because of one pill. Is it that? Am I overstating it?
No, it's so exceptionally potent. Even an experienced heroin user with a high tolerance who uses a batch of heroin that has a little bit of fentanyl in it can very easily die of an overdose, let alone a curious teenager experimenting with a counterfeit pill.
Right.
Very easy to overdose and die from it. When we think about what we need to do about the opioid crisis in general, I think we have to recognize that most of the deaths occur in people who are addicted, and that opioid addiction is a preventable and treatable condition. We can prevent people from becoming opioid addicted, mostly through much more cautious prescribing of opioids so that we don't directly addict patients or put this drug unnecessarily in people's medicine chests. But in terms of this very high death rate right now because of fentanyl, what we really need to do if we want to see deaths come down in the short run is to make treatment for opioid addiction much, much easier to access. It has to be essentially free and readily available. Somebody who's opioid addicted, when they wake up in the morning, they're already beginning to go into withdrawal. They're going to try and have opioids by the bedside so that they can have it right there to use as soon as they wake up. If that individual who's going to be very, very sick, if they don't continue using, if that individual knows where they can get heroin or fentanyl easily and it's inexpensive, but to access effective treatment, particularly with a medication called buprenorphine, is complicated and hard to get and expensive, they're just going to keep using. We have to flip it around. It has to be easier to get treatment for opioid addiction than it is to continue using.
I know I got to let you go here. You're out of time, right?
Yes.
Okay. Well, I really appreciate it because there's so much more I want to talk with you about, like safe injection sites and public policies, the FDA chief, and a million more questions. We'll have to do part 2. I demand it, sir, because I feel like I didn't get to the policy solutions enough that you've been advocating for and that would work. And I think that's important to people. But you've given us so much insight and background, and I so appreciate your time and you and your colleagues' work on this such an important issue. Thank you very much, sir.
Thank you for having me.
How about it, huh? Dr. Andrew Kolodny for the first time on the show. Check out supportprop.org. Supportprop.org is organization. He's at Brandeis University and co-founder of Physicians for Responsible Opioid Prescribing, quoted in a whole bunch of news stories. I reached out to him, got him right on the show the next day, and prepared for that a lot. And I think that was a good, informative, interesting interview, and hopefully you get that each and every day here on Stand Up. You certainly did, as always, from Dr. Aaron Carroll, who I thank as well. Thank you to Gareth Sever and Pete Coe and John Carroll and you for listening and subscribing to Stand Up. Can't do it without you. Please keep those subscriptions coming. Go to standupwithpete.com right now. Standupwithpete.com, and I will talk to you right here tomorrow on Stand Up.
Wheels been leaking grease. Boy, you better stand up. Stand up. Well, there's a whole lot more of us who know what's right. They'll keep right on ignoring us if we keep sitting tight. We got to open up the window to let in some light. You gotta stand up. That's right. You got to rise up. You got to stand up. You got to stare the devil straight in the eye. We got to let him know it's his turn to go. See it clear when all you hear is a lie. Don't get up off of your butt, down off of your fence. laying down. Boy, you better stand up. Stand up. Show your face of every color, yellow, black, red, and brown. She's the place where every lost child will finally be found. There's only one thing to do before we stand our ground, and that's stand up. Stand up. Well, the founding fathers saw the land for all. They had to stand up. They had to stand up. They had a keen imagination for a crystal ball, drawing all the plans of stand up. But all they had to go on was the time they were in, with other causes for laws, and since they weren't even sin, they knew that change was gonna come before the change could begin. They had to stand up. All right, they had to stand up. We got to stand up. We got to look the devil square in the eye. We gotta let him know it's his time to go, and make it clear when all we hear is a lie. Why you lying awake wondering where the money all went? It'll be the cost of freedom that'll go unspent. You can see him flee the scene of that experiment if you stand up. All right, we got to speak up. We got to reach up and raise your voice in every way you know how. Don't be close up. You got to show up. Ain't no better time to do it but now. No need to pledge allegiance to no wanton tribe. Rise up, show obedience to the voice inside, and listen well, and it'll tell you not to run there.